and gave one of the most, in my opinion, inspirational, sensational presidential address that I fortunately missed, and I heard so much about it that Dr. Jennifer Sanganat felt very strongly that you're the next speaker to come and join us today. Inspired by her journey as a cancer patient and as a leadership coach, I think Dr. Riall is one of the leading surgeons in the field about burnout, compassion, and how it's important that we use that in our day-to-day inside and outside the operating room. And we'll look forward to your talk today about both sides, now lessons in life and medicine. Dr. Riall, it's an honor to host you with us here today. Before I forget, group photos and then a gift. I don't want to forget that. Yeah, after the ground rounds. Yeah.
Thank you very much for having me. I have to say that I've gone on many visiting professor trips, but this has been one of the most profound experiences. I'm so impressed with you and your department and the amount of engagement you have, and I really appreciate the opportunity to see it firsthand and appreciate the opportunity to come here. These are my disclosures. So the title of this talk was inspired by Judy Collins' 1967 song, Both Sides Now, or as my husband and I like to call it, the Hordes and Hordes of Angel Hair song, because I cannot figure out what she says in the first line. But the song is about seeing things from different perspectives. In the first verse, she talks about clouds. And first, it's a child-filled view of clouds, ice cream castles in the air and feathered canyons everywhere. To then a perhaps more adult perspective. Now they only block the sun. They rain and snow on everyone. So many things I would have done, but clouds get in my way. And I can tell you that over the course of my career, I've had different perspectives on medicine, on academic surgery, on careers, and on life in general. But probably the most profound perspective I've had is my perspective as a patient. So from the youngest age I could remember, I wanted to be a doctor, and I never really deviated from that path. There's no doctors in my family, so I really had no idea what it meant to be a doctor. And actually, every year when I interview the medical students, I ask them what they think it's like to be a doctor. Because I can't even remember what I thought. However, whatever it was, I'm sure I was wrong. And then I went to college, and as I look back at that time, I feel like I wished away for potentially some of the best years of my life. I graduated college in 3 years because I was very anxious to go to medical school and to do the next thing. And for the last 2 semesters of college, I took 25.5 credits. And sadly, I don't remember, I got A's, but I don't remember a single thing from that year. And I have very few memories from college. And then I went to surgical residency, which really provided a whole new perspective. So I had the good fortune of being able to go to Johns Hopkins, where I went from being a high achiever to being very, very average. And it really provided me different perspective. I had the opportunity to do my surgical training there. And looking back at that time, those were some of the best years of my life. And I'm very grateful for my opportunity to have trained at Hopkins and for the doors that opened. That trial by fire that is residency and the relationships you develop can be replaced. I look back and I always swore that I would never be that attending who talks about what it was like when I was a resident or can't write my own orders. But now I am that attending. So, and you know, we like to tell our war stories about being on call every other night, right? It was easy to remember when I was on call because if I woke up at home, I was on call. If I woke up in the hospital, I was not. And we like to compare it to residency now, but you can't really compare it, right? In many ways, it was a simpler time. We didn't have the 80-hour work week. We didn't have the electronic medical record. We actually wrote pen and paper notes and orders. And the acuity was so much different. You know, we weren't covering all these patients, and we didn't send gallbladders home 15 minutes after surgery and colons the next day. So I think you can't really compare that experience. And I've been on the right side of many things in my life, but I was on the wrong side of the 80-hour work week the whole time. So I was an intern in 1996, and I was required to be the first person in the room. You know, I put in the Foley, I wrote the orders, I transported the patient. Then in 2004, when I became a chief resident, they started bringing in the 80-hour work week. So as a chief resident, I was the first person in the room. I put in the Foley, I wrote the orders, I transported the patient. Now as an attending, I'm the first person in the room. I put in the Foley, I write the orders, I transport the patient. I say, hey, you know, tell the residents I'm ready to start. So I was on the right side of many things, but I was on the wrong side of the 80-hour work week. And I think learning and learners are different. I think medicine is evolving rapidly, and the current learners face a lot of challenges. You know, there's new technology and new innovation all the time. So learners have to learn to operate open and laparoscopically and through natural orifices and whatever is going to come next. I think learning in some ways is more passive. We didn't have any didactic lectures, but it's a lot of didactic lectures. It's a lot less time and experience in the OR. But on the flip side of that, we have excellent simulation and things that make it easier. So I don't lament the way that it was, but I think, you know, how do we train this next generation of surgeons? And I think all of these differences converge for really a perfect storm in medicine. And you add that to the corporatization of healthcare. So when you look, it's slowly eroding the academic mission. Most modern day compensation models value clinical productivity over all else. And as surgeons, we're constantly being asked to do more with less, and we're often doing it in a system that's not optimized to take care of patients. I think in the day-to-day grind of medicine and our lives, it's really easy to forget why. To forget why we went to medical school and why we became doctors. But I would say that one of the most profound perspectives I've had was becoming a patient. So in December of 2020, amidst a spike in our COVID cases, I started coughing. And after 6 months of incessant coughing, 3 bronchoscopies, and multiple doctor visits later, I was finally diagnosed with lung cancer. And overnight, I became a professional patient. And I can tell you that that transition from surgeon to patient is difficult. Now, I'm an educated consumer. I have good insurance, but I have trouble navigating the healthcare system. I try really, really hard not to ask for favors or to do things different, but I often wonder how somebody who doesn't have a medical education, the privilege that I have, the knowledge that I have, ways to work around the system, can advocate for themselves. Banner is our healthcare partner at the University of Arizona. And Banner's mission statement, stated on their website, is making healthcare easier so life can be better. This is a great mission statement. This is a great goal. This should be the goal in every healthcare system. Banner has a patient called Sophia. That's the patient face of Banner. And their goal is always to do the right thing for Sophia. But as I step back and wonder, not just at Banner, but in the United States, do we even come close to serving Sophia? Sometimes I ask, do healthcare systems actually ask Sophia what it is that she needs? Because it's definitely not centralized scheduling. If you have a centralized scheduling system, you'll understand. When I was first diagnosed with lung cancer, I tried to get treatment at home, at my hospital. And there's a lot of challenges getting treatment at your own hospital. Those include confidentiality and physicians, often with good intent, doing things differently because of who you are. So I was referred to our chair of medicine, who is a pulmonologist, and she told me not to worry about it. And she's like, this is probably valley fever. And they sent me to the University of Arizona Valley Fever Center of Excellence. Valley fever is endemic in Arizona. And despite a negative BAL, negative Coxie titers, they treated me for a valley fever. She's like, yeah, the test is bad. You know, we see this all the time. And as I went along, I was feeling worse. I was still coughing. My scan several months later showed the mass to be slightly bigger despite treatment. And they're like, yeah, this just happens and we'll get another scan in 3 months. And at that point, I was obsessively Googling ground glass nodules, right? And I was looking at CT images that looked remarkably like my CT image. And every time I asked the pulmonologist, I felt like I was annoying her. And I felt really funny about seeking a second opinion. As a surgeon, patients come to me and sometimes they want a second opinion. And I really encourage them to do that, like to go out, because we want them to feel comfortable with the care they get. But if I'm really honest with myself, when they want to go get a second opinion at the Mayo Clinic or at MD Anderson, it damages my ego a little bit. And on a side note, it's even worse when they go and get their surgery at the Mayo Clinic, and then I manage their complications in Tucson. But finally, I sought a second opinion. And I called the Mayo Clinic in Phoenix, and I didn't even know who to see, and they recommended Dr. DeCuna. And within an hour of when I called the Mayo Clinic, he called me. He had me scheduled for a virtual visit, and one robotic bronchoscopy and a PET scan later, they made the diagnosis of lung cancer. But you need to advocate for yourself, and you need to seek a second opinion. Sometimes patients come into our clinic, or they come into my clinic, and I'm annoyed, right? Because they've read a lot on Google. They're pretty sure they know what's wrong or what they want me to do. But I've come to realize they're just trying to advocate for themselves in a system that often doesn't help them do that. This is a patient who presented with left upper quadrant pain for 2 years. He had a CAT scan in 2023 that was read as normal. He had an MRI right before he saw me that was read as normal. And then his family members, some kind of non-abdominal radiologist who looked at the scan and thought, well, maybe there's some fatty mass in the mesentery here. Our radiologist reread the scan and they addended it to read this mass. And when I look back at the CT scan in 2023, I see this. So I scheduled him for surgery. The day before his surgery, which had been posted for probably 2 weeks, the anesthesiologist canceled his case because they want cardiology clearance, despite the fact that the guy had a normal echo not long ago and no change in his functional status. They don't call me, they just reschedule him for 2 weeks. The patient calls, he's rightfully upset. So I spend hours talking to the cardiologist, talking to the anesthesiologist, talking to the OR to get him back on the schedule. When we were able to do that and we removed this mass, and he's doing quite well. But when he came back to the clinic, he said, you're the only doctor in this whole process who's advocated for me. We have to advocate for our patients. Just the other day, I had a patient with an adrenal mass, and they got a PET dotatate when he should have had an FDG PET. It was our mistake, like our hospital's mistake. And the patient called really upset because now he has to get the correct PET scan and they want another $250 copay. So I call my hospital administrator. I'm like, hey, we made a mistake. Can you please not charge him? He has to get another PET scan, but can you please not charge him for this copay? And the amount of emails and phone calls and stuff this has generated, you would think this has never happened. They literally cannot figure out how to do it. Finally, I just paid the copay. I'm like, sort it out on your end. If you pay me back, great, but I'm not going to have him pay for another scan. And we need to advocate for our patients. I will also say that things that I do regularly as a physician look really different from the patient perspective. So every time I went to Mayo, if I needed another procedure, I needed a new COVID test if my COVID test wasn't within 72 hours. And apparently I needed this done at the Mayo Clinic, which is 2 hours from my home. And somehow this infuriated me. Besides the inconvenience, are they so arrogant as to think that my hospital, can't do a COVID test? It would just drive me crazy every time it happened. When we present cases at our tumor board, we often review outside images, and our radiologists who are outstanding, no matter how good that outside image is, they recommend that we repeat the imaging at our place. I swear that if I gave them a blinded MRI from our place, they would tell me I needed to repeat it there. But in truth, as a surgeon, I like to have the images in my system, right, for a lot of different reasons. But as a patient, it's really hard to have the same test repeated. And as doctors, we fight with insurance companies all the time to repeat these studies that don't. Now I ask myself a different question. I'm like, do I really need to repeat this test? This image may not be perfect, but does it give me the information I need to do this? And does this patient who lives 90 minutes from Tucson really need to have it here, or can I get that information somewhere else? For decades now, we've been talking about regionalization of care, right? Regionalizing high complexity things to different centers. And for decades, we haven't been able to do this. And now I understand why. I went to Mayo Clinic to have my surgery, and I would go back and forth to have surveillance imaging. But when I recurred, I had my second operation there, but I had brought my adjuvant therapy back home. Because I have a full-time job, and I can't, every time I needed blood work, CAT scan, or have a complication from my chemo, drive 2 hours to the Mayo Clinic. And I have the resources to do that. So we're never going to be able to regionalize care the way that we think we can. And I thought a lot about different models of achieving the same patient outcomes without having to do that. We talked a little bit about triggers last night for people who were there, but one of the things that really trigger me now are things that waste my time. When I need lab work or a CAT scan or something like that, Banner just randomly schedules the study. And I get like a robocall, or I get some message in the portal about when the test is. They don't bother to call me and say, hey, can you do a CAT scan at 11 a.m. on your OR day? I'm like, no, I can't. So, and then if I get a phone call from Banner or from the Mayo Clinic, it comes as a generic number on your phone. And God forbid you don't answer it, then you have to call back. And you call that generic number, you got to go through their whole voicemail prompt. Then they put you on hold, and then you finally get a human being who can't help you. All they can do is send a message to the team, and it starts that whole cycle again. Charlie knows that I will go nuts if I miss a call from Banner at the University of Arizona, because it's literally another hour of my life that I can't get back. And then every time, this doesn't happen at Mayo, but it happens at Banner, every time I have a study, I pay my copay at the time of the study. Then inevitably, 2 or 3 months later, I get a bill for the thing that I paid. In fact, it's so bad that I always pay it on the same credit card so that I can find it. Because I'm like, no, I have already paid that. And calling the finance office is like an exercise in frustration. They just can't figure it out. So finally I broke down. I talked to my service line administrator. I'm like, I need to talk to somebody who can help me because this is ridiculous. So he connected me to Eileen. And so I sent Eileen the bill in the email. And she's like, don't worry about it. She's like, I fixed it. She's like, this happens all the time. She's like, if it happens again, she's like, just send it back to me. And while I appreciate the workaround, and what Eileen does for me certainly lessens my aggravation, we're missing the big picture. Because this is happening to our patients every day. And my patients are either paying that because they don't know better, or they're getting sent to collections. But we need to fix the system. Every day in Tucson, and I'm sure you do this here, I create a million workarounds to do the things I need to do. I joke about it, but everybody in Tucson has my phone number. Because if you're a referring physician and you send it through our system, who knows when it will get there, how it will get routed, whatever. So they just call me, they give me the patient information, I send that, I set everything up from there. I joke about it, I say I'm the triage nurse for all of Tucson. If someone has a problem, they just call me, I will figure it out. But that's what we need to do for patients. But I can tell you that sometimes I'm resentful. I'm angry, I'm on vacation and I'm getting called by referring physicians. I'm getting called by patients. And I think, I can't do this anymore. And Charlie says, you can't take all that on yourself. He's like, you need to let the system break. But I can't let the system break because you always have to remember that there's a patient on the other side of that. And patients really appreciate it when you go that extra mile. So there's a lot of things in medicine that block our empathy. And I can tell you as a patient, I've seen empathy and lack of empathy firsthand. And I can tell you that empathy and connection make a difference in the patient experience. I learned a lot about empathy from Winston. So Winston is an incredibly spoiled 8-year-old golden doodle who's changed my life in amazing ways. So I always say in every life you get one soul dog, and Winston is mine. But when I'm sad, Winston just knows. He just comes over, he lays down, he puts his head in my lap, he says, Mom, you're not alone. He doesn't tell me it's going to be okay. He doesn't minimize it. He doesn't offer solutions. And he definitely doesn't tell me about a time he had it worse. He just sits there and absorbs that sadness with me and lets me know I'm not alone. What my experience with Winston also tells me is that you don't have to experience what somebody else has experienced to have empathy. You only have to be able to connect with the emotions. And again, I experienced empathy and lack of empathy firsthand as a patient. In 2023, when I recurred, I went back to the Mayo Clinic and I had the remaining parts of my left lung removed. And after that surgery, the surgery went well. Dr. Takuna came out and talked to Charlie. And so in typical surgeon fashion, I'm like, I'm going to be out of here in 2 days. Then that night, I heard the air leak. It was like this continuous air leak. And every time I took the chest tube off suction, I'd be subcutaneous emphysema and I'd be short of breath. And I was worried about it, right? I know just enough to be worried. So I called the nurse, who was incredibly dismissive, and she's like, rolled her eyes. She's like, we see this all the time. I'm like, not this kind of air leak. But at any rate, I called her back a couple hours later because for some reason the fluorescent light over my bed wasn't working and I couldn't turn it out. So now I'm like worried about this air leak. I can't sleep, but I have a headache, because this light is on. And she came back, she's mad, she can't turn the light out either. And she's like, I'll call facilities. And at that point I was afraid to ask her anything else. So I just said, I'm worried about this air leak. I can't sleep. I have a headache. About 2 a.m, the MA comes in and I asked again, I'm like, can someone please just call facilities or change my room or whatever. And the nurse kind of stormed back into my room and she just looked at me. She's like, I have patients who are sicker than you. I was like, okay, that's probably true. I'm sure there were, but that didn't make my night, any less awful. And then in the morning, I heard her like signing out to the other nurse and she's like, that patient 23, that was me. She's nuts. And so, I think a lot about that experience. The next day they put on a portable suction device so that I could walk around the hall and obsessively watch the volume of the air leak. But as I think about that experience and I think about how those nurses' words affected me, I think, well, was I crazy? Probably. What person walks around 10 miles in the hallway in circles with their chest tube? So probably I was. But at the same time, is that, you really think about it, you can see it from different perspectives. Because I've often walked around the hall and said, wow, that patient is crazy, even recently. But I think as physicians, if we can't joke and empathize about some of the absurd situations that we find ourselves in, it'd be really hard to navigate this space. And for me, I deal a lot with humor or sarcasm. So when I'm in the operating room and they give me something I don't like this smoke evacuating bovie, which, let's face it, that ship's already sailed. I always tell them, I'm like, hey, put this on my card because that's the only way I'm sure never to get it again. So, and like I'll joke, and we had a patient who I said to the residents, like, but he has to go home tomorrow. I said, he's mad sick, Medicare was one night of mad sickness. And we just sort of waiting. See if this happens or not. So sometimes patients sometimes they're
All
right. Let's try it out. Anyway, what I was saying is sometimes patients are crazy. Sometimes they're quirky. Sometimes they can just be mean, but they're also scared. And in my practice, they're often dealing with cancer. And so I always think that what we do every day is routine, but it's not for patients. And we have to remember that. Also, I can tell you that when patients are really sick, they don't believe that they're going to get better. That air leak kept me in the hospital 10 days. And I felt like I was a shell of the person that I used to be. I felt like I was never going to be back to myself. When I have patients who have complications like a pancreatic fistula or delayed gastric emptying, they're really frustrated. And I'm really frustrated. And they think they're never going to get back to the way that they were. And I used to go in and tell them, I'm like, oh, it'll be okay. You'll get better. You won't remember this in 6 months. But now I kind of approach it differently. I take a lesson from Winston. I don't go in and try to tell them it's going to be better. I just kind of sit with them, tell them I'm sorry they're having this experience, and just let them feel what they're going to feel. And I also remember that patients are balancing many things. So I used to get really frustrated when I would see a patient and I would work to get them in the OR schedule, often moving things around to get their cancer surgery done sooner. And I would be shocked when they would say to me, they're like, well, I can't do it on that day. And I would think to myself, you have cancer. Like, what is more important than this operation? But people don't plan to have cancer. They don't plan to have operations. When I recurred, we were supposed to go on vacation. And then Dr. DeCuna talked about doing surgery in early January. So this is right at the end of December.
Now I'm going to show you Burger King CEO release a video of his own. Now, back to my bite. What? And earlier. What happened? Sorry, we lost.
just ask them how they are and I just listen, because otherwise I either minimize their experience or sometimes I put them in a position where they're afraid to tell me what they're really struggling with. And I'm actually shocked to find out that when I listen, there's often many things that they're experiencing that I can address, and some I can't, and I just need to sit with them and listen. I think being a physician is an incredible privilege, but it's also an incredible responsibility. And I feel that burden more now after my personal experience. Patients ask, well, why did this happen? And I don't have a better answer. I'm like, sometimes it's just bad luck. There is no why. But it's really hard to sit across from some young, previously healthy patient who says, you don't understand, how do I live every day knowing that I have cancer? How do I tell my family? Of course, I do understand, but it's really not about me. I do at times share some of my perspective with patients. There's a 1972 made-for-TV movie called Brian's Song. And in the beginning of that movie, the narrator uses this quote. He said, Ernest Hemingway said that every true story ends in death. Well, this is a true story. Charlie and I used to joke about, he's a little older than me. And I said, look, if you die, I'm like, I don't know how to work anything in this house. So it's like, anytime something would come up, I was like, you need to put it in the death manual. We actually have a file on our computer called the death manual, and it has things in it. Like we have a 5-way light switch and it's not wired correctly. So you have to have like one of the lights on for the other 4 to work. And you just have to know that. We have 4 air conditioner units and one of them takes a different size filter. And if you want to turn on the pool misters or the misters outside, you have to turn on the pool remote and then hit the up button. And you just have to know this stuff. So we put it in the death manual. We still have the death manual. It's just that now it's a lot less funny. But I think a lot about, getting a diagnosis of cancer. So we all know that we're going to die, but it's an abstract concept. I think what happens when you get a diagnosis of cancer is that you're sort of faced with your mortality in a very real way. And I think everything changes and then actually nothing changes because you still don't know when. So how do you sort of navigate that? You have to go about your life. I could leave here tomorrow and get hit by a car, right? So I always sort of share that with my patients. I always tell Charlie that I want the last check I write to bounce. But of course, I would need to know when. He gets really frustrated. He's like, you can't think about it that way. $100-kilogram person, do I need to do this for 3 years? What's going to happen when I stop it? Because when I've had to stop it, I get new lesions on my scan. She can't answer those questions. We don't know, right? But maybe that risk benefit discussion is different in a 55-year-old who's trying to do a full-time job than it is in a sedentary 70-year-old. I just stuck out the 4 years. I stopped it like a month ago. So my fingers are healed and my nails are growing out. But I'm scared every day, right? Like what will happen? And we don't know. I'm going to spend the last few minutes just talking about shifting perspectives on research and academics. And just one piece of advice for the residents and the students in the audience. So when I was in Galveston, Dr. Townsend always used to sign his emails KO to tell me to keep on keeping on. And I always tell Charlie, you know, I'm not really good at anything. I am not that smart. I'm not the technically best surgeon. I'm terrible at any sport that has a ball. And while I like to run, I'm not really built for distance or speed. But what sets me apart usually is my ability to just work really hard. Dr. Townsend always said, don't bet against her because she will do that. People think that you need motivation to succeed. And you do need motivation to start. But that's not what you need to succeed in the long term, because motivation waxes and wanes. You need consistency. You need to show up every day and do it even when you're not motivated. There's a TED Talk or a talk by Simon Sinek that I recently watched. And as he's talking about consistency, the power of consistency, I thought, well, this is obvious. But then I realized that in its simplicity, it's not. It's obvious, but it's really difficult to do. And he gives an example. He says, suppose that you want to get in shape and you go to the gym and you work out really hard for an hour. You come home the next morning and nothing's different. So you go the next day and you work out for an hour and guess what? Nothing's different. So people quit. But I guarantee you that if you go to the gym every day for a year, you'll get in shape. You can't pinpoint the exact time that happens, but it will happen. And so I've come to realize that I used to think that my superpower was being able to sleep any place, anywhere, anytime. But actually my superpower is consistency. And I think about that in every aspect of my life. And I would just encourage you to think the same. When I was a resident at Hopkins, I started their pancreatectomy database. And you could argue that it had a lot to do with timing and opportunity, but it was the consistency and taking advantage of that opportunity that allowed me to capitalize on it. When I met Charlie, I was worth like negative $150,000. And from the time we could, we invested small amounts every month in dividend producing stocks, nothing sexy. And that's what leaves us financially well positioned now. Some people can wing a marathon, but I can't. I have to get up every day and I have to run, in order to do that. And I mentioned the same thing about work. I came to the University of Arizona and there are days when I'm like, gosh, I'm not making any progress and I'm so frustrated, but I can look back 10 years and see what I've built there and what I've achieved. And so I would say, have that consistency, do that every day, because that's going to make a difference. And I always tell people and my patients, when it gets really hard, I just break things down into the next increment that I can mentally handle. I just commit to run the next mile, to run to the next water station, to take the next step, whatever that may be. And I tell my patients the same. My first presentation was at the SSAT in 1997, and I gave a talk on duodenal adenocarcinoma. Now, I can't remember what I did 10 minutes ago these days, but I still remember every word to that talk. Like, I was so excited to present there, and I felt like what I was doing and what I was presenting was important. Now I'm a little more cynical, about surgical meetings. So I review for many journals and I read a lot of bad articles, many of which get published. And as an academic community, we have mined the NCDB and the nationwide inpatient sample and NSQIP, to death, often getting the right answer to an unimportant question. And how many papers are we going to write that show that people who are wealthy and have insurance and get operated on by high volume surgeons do better? We know that's true. And we know that's true for whatever disease process that you look at. But both perspectives aren't true. Sometimes I say, has anything I ever written helped anybody? And of course, that's not entirely true, but these things are important. As I mentor residents and I see them go out and present, they felt like I felt in 1997. And presenting these papers, even if they're not earth-shattering, right, it teaches them to understand statistics. It teaches them to read the literature critically. It teaches them to ask and answer questions to the challenges that they face in their clinical practice and collaborate with basic and translational scientists to do that. And going to those meetings helps them advance their career and network. I think career advancement is important. But sometimes I go to surgical meetings and it's like this whole world of people who are afraid of coming in last, right? You hear the Facebook version of everybody's lives, their accomplishments, their new leadership positions, how many Whipples they did last year. And it's really easy to feel like your stuff doesn't measure up. The person in this picture is Herb Zay. I trained with Herb, and Herb's the chair at UT Southwestern, and he's one of the people I respect more than anybody in the world. You know, he's never self-promoting, and he's just quietly at home, you know, answering the questions that are important to patients. And you can see that in his body of work. Herb always says, he tells his residents 3 things: never read or believe your own hype, you're only as good as the last patient you operated on, and never count your Whipples until you see them in the clinic at 8 weeks. I think my experience has changed my research perspective. So I operate on patients with pancreatic cancer. And well, every once in a while I hit a home run. The reality is that the prognosis is dismal, and most of my patients die of pancreatic cancer. And that operation has significant impact on their quality of life. And while I realize that some people want to extend their life at all costs, other people really value their quality of life and their functional status. As a surgeon, I can give them data on mortality, morbidity after surgery. I can give them data on long-term survival, but we don't have good data on quality of life and what that experience is going to be like, nor do we have any training in being able to elicit their preferences and help them make decisions aligned with those goals. This is Dr. Galuzis. He's a resident in our program, and he came in my lab in 2023, and we started a longitudinal study of quality of life. So we talk to patients, we do the surveys before surgery, at their first post-operative visit, then at 1 month, 3 months, 6 months, and a year. And we look at quality of life and decision regret with a number of tools. And it's really provided fascinating data. In a cross-sectional study that we did before the longitudinal study, and in our longitudinal data, about 20% of patients have significant regret after pancreatic surgery. And not surprisingly, that regret changes with time and recurrence and all different things that may happen. And it's really fascinating doing the patient interviews and sort of learning from that. There's a qualitative component to the study, but we've had a lot of really actionable things to improve. You know, we've started an APP protocol where we hire an APP and we improve the transition from inpatient to outpatient. She sees patients within 72 hours. So when they don't get their insulin or whatever thing happens, you know, we're able to decrease our length of stay, decrease our 30-day mortality, and decrease our failure to rescue with early recognition of complications. We also have a donor whose husband died of pancreatic cancer, but she really highlights the challenges that we have in continuity of care and some of the challenges that PCPs don't feel comfortable managing. And we're starting a post-pancreatectomy survivorship clinic that's funded by her that involves some integrative components. This woman is my oldest patient I did a Whipple on. This is her 92nd birthday. And, you know, I had her talk to one of my patients who was 80 something, you know, who needed a Whipple, and really put that patient at ease. And then I took the 2 of them out to dinner. They're just adorable. But we started a peer mentoring program because a lot of patients really commented that, you know, they have challenges that we as physicians either don't understand, and really talking to somebody who's been through the experience helps them navigate that. So we have a process in place to get informed consent, to educate those peer mentors, but we're trying to pair people who've had similar pathology, similar demographics as we get a big enough cohort. And finally, surgical meetings. So my first surgical meeting was the American College of Surgeons when I was in medical school, and they sent me to their medical student program. It was one of the greatest experiences of my life. It was my first surgical meeting, and we had access to all these sessions, and I got to hear talks from these people who are like literally legends to me. And we were open to go to any session. And I went to so many sessions. I was like just drinking in all this information. And this is in contrast to going to surgical meetings now. Like the American College of Surgeons is like an exercise of running from one hotel to the next hotel to go to committee meetings and different things. And the only sessions I go to is something that I'm moderating or asked to speak at. And the whole experience has really changed. Surgical meetings used to be to advance the science, to get the experts together, to collaborate, to make the care for our patients better. And somewhere along the way, we lost that. As a leader in these societies, I often have patients or people come to me and say, what is the value of being a member of the SSAT or fill in the blank, organization. And I think, there's value. You come, you get to present your work, you advance your academic career, but maybe we're asking the wrong question. And so to paraphrase John F. Kennedy, maybe we're asking, instead of asking what these societies do for you, what do you, through your membership in those societies or the academic community, do to improve the care of your patients? We need to go back to coming to surgical meetings to share ideas and not it being solely about self-promotion and making the care of our patients better. So as I close, I think about my experience. I think about the last 20 years of my career. And I think somehow I've come full circle. Is all the work that I'm doing earth-shattering and life-changing? Maybe not. I didn't invent angiogenesis inhibitors or targeted therapy for cancer. But every day, I'm a good doctor. I show up and take care of my patients. And I've had the privilege of mentoring young residents who do the same. I see the benefit of advocating for those patients, and I see the value in that. So as I leave, I'll paraphrase Judy Collins. She's like, now it's just another show. So I hope I leave you thinking as you go. And I'm happy to take any questions.
Thank you so much. This is wonderful. Questions for Dr. Riall?
This is my other puppy. I love her too, but not as much as Winston. That's why I can't have kids.
We typically ask visiting professors, what advice do you have for all of us, students for life, or students of life?
I think I've, shared some of it in the last few days, but, we talked a little bit about this last night. It's really having this identity outside of what I do, and then really bringing that identity to everything that I do. I think you talked about it. It's like my North Star, right? Like I always know, why I'm doing the things I'm doing. And I think that's helpful.
Thank you very much for a great lecture and for sharing your story. I guess as someone who's had a lot of chronic health issues, I wonder what your thoughts are about backing away from some of the incredible responsibilities that you have to spend more time with Charlie or Winston or yourself.
I think about it every day. Every day I have that question. I have that conversation with Charlie. I've actually started to look into retiring, and it's frightening, right? Like that other side, right? For years, it's like you're saving money. And now you think, oh my gosh, and I think, can I do it? Am I ready? What does that look like? I think more and more, one of the challenges I have as a surgeon is like I have this all or nothing mentality, so it's like either I'm going to work like I'm working now or I'm going to retire. And there's probably a lot in between that I can do that will meet all the needs that I have. But I've very slowly transitioned away the things that don't make me happy. That's not to say that everything I do makes me happy, but I do it for like a purpose and different things. But I think every day about when that time is and, wanting to enjoy my beautiful home and the view and not be aggravated and not be working and not be called all the time. I said my ideal job would be to retire and then to just go and help my partners operate. so like none of the patients are mine. I could just operate every day and then just go home. I told my scrub tech I was going to be a first assistant. I was like, I'd be really good at it. She's like, you'd be terrible at it. She's like, you'd be like, I wouldn't do that. It's just like, so she's like, you shouldn't be a first assist. Yeah.
Other questions for Dr. Hill, in person or Zoom? Do we have? Thanks.
Thanks for the presentation. Something you said last night kind of resonated with me, and I reflected on a little bit last night. You mentioned a resident that came to you, and they said they can see the light, or alluded to seeing the light at the end of the tunnel. And then you mentioned your experience in the OR where you walked in and you had the thought of, I'm the only person in this room who knows how to do this procedure, right? As an experienced surgeon, what do you say to, and through that talk, you kind of alluded to staying in the moment. As a junior resident in the first year of my training, right, and hearing your story through your career, what advice do you give to us on how to navigate staying in the moment? And when did you notice that switch? Like, how did you navigate going from thinking I can just get to the end of this rotation to, you know what, I have it down packed. I'm the only person who can do this. So how do you navigate that mentally?
I think it's a tough question to answer, but I think, as residents, and I mean, even now, like I want to finish, right? Like I want to finish this case, or I want to get through this week, so that I can go on my vacation, or like whatever that thing is. So we all do that, throughout our whole lives, but take advantage of the things you have now. I think about our residents, and they'll complain about this service or that attending, but every time you're in there, you think, what am I going to gain from this experience, right? I have to leave here and I have to take care of patients. And so I can learn as much from somebody I don't like working with as I can learn from somebody I'm working with. So how do you just say, I'm going to get the most out of every experience that I have, good and bad? I'm going to go in every day and say, okay, I don't like Dr. Riall, but she's got a lot there's a lot I can learn from her, good and bad, right? And how do I take advantage of those things? And I think if you shift your focus to saying, like, why am I doing this, right? In the big picture, those bad days get better. And I think to your point, in my job as a division chief or a department chair, right, there are parts of that job that I don't like, right? Everybody has that. But when I can say, I do it for this purpose, yes, I don't like this thing, but I do it because it matters to the people that I'm advocating for, or it matters to this. And I can really shift that focus to, I want to do this. And it's not something I just have to get through to get to some next perceived finish line. That you're just going to change that goal as soon as you get there anyway.
So some of the issues that you talk about with, the current quality of research, the meetings, how do we get back to just like, what are some steps that we can start to take to get back to just sharing information, bettering patient care rather than the current kind of state of things? Because I think a lot of trainees find that you have to publish, you have to continue to build your career, but at the same time, you really want to contribute and you really want to find that improvement for the patient at these meetings and in your research. What are some steps that people need to, even collectively, need to start moving back towards that direction?
Yeah, and presenting at national meetings and advancing your career is not mutually exclusive with doing those things, right? But, I recently had an experience when I was doing this study, I wanted to get other centers to collaborate. And there was a lot of people who were like, no, we have our own thing here, and they don't want to do that, which is fine. But I think to myself, well, how do I model that, right? How do I go out and find the people who are going to collaborate with me? Because they're out there. There are tons of people out there who want to collaborate, who want to do this. So when those people tell you, look, I got my thing here and, we're not going to share it, that's fine. But there are plenty of people out there who want to collaborate, who want to have that environment. And I've changed my view. For a while, I didn't go to a lot of meetings because I was, just kind of cynical. But now I see it again, sort of through a fresh perspective, right? So I go there and I actually listen to the talks. I went to some meeting, I didn't have anything to do. I could like just literally sit there and learn. And I remember why I liked to do it. So go learn, listen, participate. Don't just say, I have to go to all these meetings and I'm too tired to go listen to the part where I actually learn something. And you'll find that people who want to collaborate, they're all around you when you look.
Excellent question, Dr. Riall. Thank you so much for a sensational inspiration ground round.